Welcome to our panel on how social care reform can succeed. I used to think of these sort of panels as the view from the long grass, but I think really we're now in the shrubbery in terms of where social care is in political priorities. But as has been the case throughout this morning, we will try to look for pinpricks of brightness and talk about the opportunities of the government's social care commission that it has announced. It does have a long-term deadline of 2028, but there is an interim report due next year with medium-term solutions, and it would be great to hear from the panel about what they think medium-term can be defined as and how much impact that can have. We're going to start with a presentation from Natasha Curry, who's the Deputy of Policy at the Nuffield Trust. And then we are also joined by Melanie Williams, who is the President of ADAS and Corporate Director for Adult Social Care and Public Health on Nottinghamshire County Council. Nadra Ahmed is Chair of the National Care Association, and Thea Stein is, of course, the Chief Executive of the Nuffield Trust. So we're going to have a great discussion. We'll start with Natasha's presentation for about, she said a slightly longer amount of time than the other speakers, but
I promise
possibly.
I won't talk for too long.
The history of social care failures.
That would take too long. I've done a summarised version of that. So yeah, just to kick off the discussion this morning, I'm going to reflect on what we might be able to do this time round to make social care a reality. And I'm going to be reflecting on some of the work that the team and I have done at the Nuffield Trust over the last few years about what we can learn from other countries. But before getting right into the weeds of the social care reform debate, I want to just situate us in terms of the broader shift between hospital to home and where social care really fits in this. Because I think the language around the shift is very NHS focused, it's very health focused. And the framing of social care in the debate is often, well, social care is a support to the NHS. We need to reform social care to fix the NHS. I don't think that's wrong, but I think it forces a very narrow focus on the intersection, the Venn diagram between the NHS and social care. And inevitably, the conversation becomes about fixing delayed discharge. Occasionally a little bit about admissions avoidance, but mainly delayed discharge. And all focus and resource goes onto that small activity. And actually, by doing that, we're fixing the symptoms. We're not getting to the underlying cause of what's driving the problem. The underlying causes sit within the social care system, and I believe we need a wholesale reform to social care. And for that to happen, the starting point has to be that social care is a public service of equal importance to the NHS, and it exists in its own right. So that's my starting point. And from there, I will just reflect on the journey of reform so far. We've just had a new review announced, but if we look back over the last 25, 30 years, there's been a tale of repeated policy failure. We look back to the end of the 90s, we had a Royal Commission, followed by 2 further government-led commissions, 3 independent commissions. I lost the will to live when I was snipping the front pages of parliamentary reports. We've had about 14 parliamentary inquiries and reports, 3 white papers, and now we have another commission. So what can we do to make it different this time to actually affect reform? I'm hoping the panel can get into this discussion. But just to set us up, I wanted to talk about some of the work that we've done over the last few years looking at other countries. Why do we look at other countries? Well, because we're not unique in the challenges that we face. We often think we're quite unique in our systems and processes, but we're not unique in the challenges that we face. We have an ageing population. Other countries have an ageing population, more rapidly so. We have an increasingly challenging dependency ratio. We also have increasing numbers of working age adults living longer with disabilities, long-term mental and physical health issues. So we're not unique in the challenge, but we are an outlier internationally in how we've failed to address the solution to supporting people. And we've looked at a number of countries around the world. We've looked at Japan and Germany in depth as 2 examples of countries that have started in a not dissimilar place to where we are. They had concerns around availability of care, cost of care, quality of care, responsibilities falling to unpaid carers. And they have managed to create functional social care systems out of that position. And they've done that in, I think, two lessons to take away from how they've gone about that is that they've set about a comprehensive reform. They've not tried to tweak around the edges and fix bits of a broken system. They started from scratch and they thought about how a system should work and what the elements were that had to work together. They also set out clear principles around what would be fair in their context. And going back to some of the discussions earlier about international comparisons, we have to be mindful that the cultural and social context differ. But that aside, I think there are certain design principles that they base their systems on that do transfer and translate across boundaries. First is around financial sustainability. So they identified a source of sustainable revenue to fund their systems. They set about pooling risk so that individuals do not bear catastrophic costs. If you're unlucky enough to have a long care journey, you shouldn't have to bear that risk. We subscribe to that notion in health. Why not in social care? They had a conversation, a national conversation about where the balance of care and cost should be between the state, the individual and the family. These systems are not free at the point of use, but they've tried to contain the individual contributions by capping them on a monthly basis. They also set about establishing clarity and consistency in their systems. So there's consistency in terms of how you access services and what you're likely to, what the type of services you get, and the eligibility assessment processes are nationally set. So there's a consistency and a clarity over what you will receive. So if you have a certain level of need, you will be able to access a certain level of monthly benefit. They also thought about providers. So if people need care, you're going to have a vibrant provider market. And they deliberately thought about, well, how can we stimulate a vibrant provider market? How can we make that sustainable and innovative? And they did that through a national fee schedule. So providers have a minimum fee on what they're paid according to the type and complexity of the service that they're providing. And then finally, flexibility and adaptability was built in to the design of the system. So as circumstances have changed, as population have got older, as the financial context has changed, because they've established the building blocks of a functional system, they've been able to tweak those elements as situations have changed. So how did they do it? What was different about where they started to where we are now? I think there are a number of things that made the conversation different in these two countries. And you'll notice a French flag in there that I've thrown out. I'll come back to France in a second. But I think where they started was a real recognition of what the problem was. What were the problems that they were trying to face? And they framed those problems as societal and wider economic problems. If you don't have a functioning social care system, you can't have a functioning society and economy. And that was there was a groundswell, I think, of public discontent about access to care, and it became impossible for politicians to ignore that, and they had to take action. A window of opportunity then opened up in Japan following the economic crash, in Germany following reunification, which changed the political and social discourse and forced conversation about social care. In Japan, it was very much focused on unpaid care and the number of people who are unable to join the shrinking workforce and the need to get the economy moving. In Germany, it was much more about solidarity and what's fair as East and West came together. So there was a window of opportunity. We have a new government. I think we have a window of opportunity. They then built on that groundswell of discontent amongst the public by establishing a positive framing about establishing social care as a pillar of national infrastructure. They didn't start by talking about individuals, burdens and costs and who should pay. They talked about it as an investment, a positive investment that is necessary for the economy and society. Then they went about designing systems that actually addressed the problems that people were facing in their day-to-day lives. And then there's been a process of negotiation, and as I said before, they've adapted and evolved their systems. That blue line at the bottom that fed through all of this was political will and consistent leadership, people pushing forward towards a consistent vision and being bold in political choices. And the reason I put France in there was quite an interesting case study. So the French social care system is not dissimilar to ours. It has many, many challenges. It had a really difficult time during COVID. But France has used that, the fact that COVID has made social care much more visible to take steps towards reforming their own system. They've recently announced that social care is going to be the 5th pillar of their welfare state, so alongside health and pension. So it's got that political priority and visibility. So how can we get there here? I think there are a number of barriers and obstacles I'm sure the panel will talk about in a moment that we need to overcome. So one of the fundamental problems we face here is that there's low public awareness of what social care is. About half the population believe it's free as part of the NHS, and it comes as a horrible shock to people when they find that it's actually means tested and quite mean in the means testing. That makes raising increased taxes or contributions quite politically complex, and we've seen how toxic that has become in previous elections. I think social care suffers from an invisibility problem as well, and I think the previous panels have touched on this. You can cut the ribbon, I can't remember who said it earlier, you can cut the ribbon on a hospital, you can see ambulances queuing around the block. The crisis in social care is happening in private homes behind closed doors. It's very difficult to see the unmet need and people struggling. And as I said before, I think the starting point of debate here has been about individuals and costs and burdens and how we can protect inheritance and property, instead of talking about the wider framing of why, as a society and an economy, we need a social care system. I also think that reform to date has tried to tinker at the edges and address maybe a workforce issue or catastrophic costs, but without thinking about how those different bits intersect and depend on each other. We need an overarching plan. We might be able to do incremental implementation, but we need a plan with all the elements working together. But I think one of the biggest barriers, and I'm sure we will come on to this with the panel, is the day-to-day instability of the system and the funding constraints and just the starting point of the sector as we are now, and getting the headspace resource to be able to bring about the reform that's needed. So I think what we really need now is for social care to be put up alongside the NHS as a political priority, and I think we need to see greater urgency as we've seen in the NHS over the last few months. So I will leave it there and hand over to our panel.
Thank you so much. Thank you, Natasha. And I think this relates to the first discussion that we were having, which is you get a clear sense from your presentation that the government doesn't quite know, and when I say the government, I really mean successive governments, what question they're trying to answer and what they would like to see at the end of this as well. Nadra, just tell the audience firstly a little bit about the organisations that you represent, and also what question you think should be being asked as Louise Casey gets going with her review, and you know, if there are medium-term solutions that would make a big impact, what are they?
If I had the answer to that. No, I do have an answer to that, but I'll come on to that. So I'm the exec co-chair of National Care Association, which is the organisation that represents small to medium-sized providers predominantly. So this will be people with 4 learning disability services to somebody who owns 38 homes, but we consider it medium-sized because it's one owner. It's not a corporate style kind of management service, and we've been around since 1980. So it is one of the most established of all the national bodies that represent. So and National Care Association is also part of the Care Provider Alliance, which is an alliance that's made up of the 10 national bodies that represent the corporates, the not-for-profits, the learning disability, mental health. So we are in that space as well. And one of the things that Brexit and COVID did was we also work with the NHS in different levels. So we're also part of the Cavendish Coalition, who was set up during the period of Brexit when we knew there would be challenges around the workforce. And then there are a number of groups that we now are working with within the NHS, which are led by people like Sarah Jane Marsh, who to look at the discharge. So we sit on those task forces as well. So it's kind of, we're trying to spread quite thin. I have to say it's a very small organisation. We're not very, very big. I don't have millions of people working for me. It's like 4 people, 6 at most. So it's a very, very small organisation because partly it's there for the affordability of the smaller providers. I think that the challenges have been outlined really well. We have had so many commissions, we've had so many white papers, we've had so many. We know what the issues are, actually. Basically, we know what the challenges are that are there. And one of them has been highlighted really well, which is the complexity of the people that we support. So so I started in 1981 when I opened my first home. It was in 1981. I was only 5, but you know, that's how long ago it was. And actually, people came into my home. They drove in. They handed over their social security cards and said, "We want to stay in this home." So they made that positive choice that they didn't want to live alone anymore. They didn't want to be lonely. They didn't want to have to pay bills or think about cooking or whatever it was. So that's how it happened. By the time I came, I wouldn't take anybody with incontinence either or anything like that. But by the time I came out of the market, which was in the kind of late 90s, early 2000s, we were taking people with reasonably complex healthcare needs. And now what you have to think about is social care is doing a healthcare task. We are looking after people at the end of life care. We're looking after people with stroke management. We're looking after people with complex disabilities. But actually the funding has never followed. And that's the issue. The funding has stayed within the NHS. With all due respect to all colleagues here from the NHS, it's actually stayed in the NHS. So social care has had to keep on fighting, and yet we've now become part of that health response, if you like, in making sure that people are supported. And we're still letting down 500,000 people still waiting for assessments. We know, and we also know there's about 4.5 million people who are looking after their loved ones in their own homes. So all of those points are really challenging because we've really not kept up. And that, I think, is the challenge that I face. I mean, the taxi driver that brought me here this morning had never really thought about social care. And then you'll find others who will have thought about it. He said, it's never affected me. But if my mum was sitting on a trolley in the NHS, I'd be cross. Mm-hmm. And that's the public bit. And I think that's one of my solutions, is how do we get that public messaging out there, that people understand it might not affect them today, but it will affect them as they go, or they'll have a loved one. And I've had, you know, having worked in the sector for this length of time, I've seen so many changes. And I think the SME providers are saying to me today, even as I was coming up today, we've had people saying we can't carry on. And there is a massive funding issue here now. The rise in national insurance contributions alongside the bringing down of the threshold will have a fundamental impact on somebody who's telling me they need to find £200,000 in order to meet that. So I think the funding issue is a massive issue, but it's not the only issue. I think it's the value of social care. We cannot be the invisible arm of a health option.
Yeah.
We've got to be centre in here, and we've got to make that work. I could go on forever, so do stop me.
I think we could all go on forever.
So I'll
on
stop
this.
because of my colleagues.
Just to encourage you to speak for a bit longer, just briefly, the NICS issue is obviously a deeply acute one. How well understood is it by those in government who you are talking to? Because from my perspective as a political journalist, it's coming up in the Commons, it's often raised as one question at PMQs, and then everyone moves on. And it doesn't seem to be getting the... it doesn't seem to be a sticking issue yet in terms of it being a big political row. You know, we have not had the kind of... Westminster has this habit of spending a week getting very cross about one thing. And grooming gangs last week was a classic example. We haven't had the NICS week for charities, social care providers, hospices and so on. I think if I tried to have my own week of getting angry about it, it probably wouldn't work. So in terms of within government, how appreciated is that as an issue?
Well, I kind of moved on from the announcement, from the shock to the angry, and now I'm getting angrier, if you like, because I don't think there is any recognition. I truly think that the Prime Minister, the Chancellor and Wes Streeting think this will go away,
Right.
that the sector will be able to cope with it, because what they look at is the corporate sector, which is about 10 to 12%, who've got that, they've got that buffer. What they don't realise is 84% of the sector, maybe they don't care,
Right.
but 84% of the sector is SMEs. They are not going to be able to cope with it. And so when I hear a politician saying, but you've always said that, I had this, and it was good job it was a Teams meeting, because it's one of those things where you just sort of want to grab somebody and say, hang on a minute, well, you said this in COVID.
Yeah.
Well, yes, we did say it in COVID, but in COVID, the then administration made the decision to give us small bits of grants. They were never going to be sustained, but they were small bits of grant that helped. And in some ways, they caused a bit of a conflict because, pay if somebody's got COVID became an issue. All of those things became issues. So I do think the politicians either don't get it. I think we've got a whole set of new politicians. There's a huge majority. We've got a whole tranche of new politicians who actually either don't understand it or it's not the top of their list. Health will always be, and let's be honest, we all want health to succeed. And as a sector, we in social care want health to succeed. We want to be helping with discharges. I get really fed up when I hear the Secretary of State saying, well, the reason for the mess that this is, so there isn't capacity in social care. Well, hang on a minute, there is capacity. I've got providers who through Christmas and before and now, I'm thumping this dress a bit too much, have said to me that we've got capacity. We have capacity. We've got home care providers actually telling us that we're not being contacted. And part of that might be to do with the funding. So a care provider, if he or she is presented with a case of come and assess somebody in the NHS, in a hospital setting for a discharge, and if that person's got delirium which isn't under control, for example, bringing that person into a care home setting, a smaller environment, will cause an issue. And so the providers have to look at that. And if the funding is £700 a week, you're not going to be able to get extra staff for that. You're going to have to fight. We're having to fight for CHC when it's completely legitimate that person should be getting it, and that's wrong. I think we've got to get this system. It's the system fix that needs to happen so that we get to where we need to be. So I think the sector is always ready to support, but now I think the sector is getting to a stage which, quite by accident, we've got Providers Unite that's emerged out of a letter I wrote to the Chancellor. It was not intended to be in that way, but now we've got about over 2,000 people signed up to agreeing with us on that letter and wanting action. And I think that will happen. I think the provider will get up now. So
I guess the rejoinder also to you're always saying this criticism is, well, you're always failing to reform social care so that you can, you may be making the same complaint about a problem that has been failed to resolve for quite a long time. But there we go. Melanie, I'm really interested in your perspective from a local government standpoint, where actually, we talked in one of the earlier sessions about other countries using penalties for local governments, and I can imagine you probably thinking, no, that's definitely not a good idea. But in terms of the current situation, in terms of the amount of need and the awareness of the amount of need, my understanding is that measuring that is still quite difficult. So local authorities aren't able to know how much need there is and how much need they're meeting.
I think we've got some good estimations of that. So health and wellbeing boards are pretty good at understanding their local populations, gathering data and bringing that through. So I don't think it's that we lack that. Okay. And certainly local government can report on its activity with people. But I think a number of people have touched on this throughout the session. So adult social care is about home. It's not about hospital. About 0.5% of what we do is about hospital. It is about home. And I think fundamentally we don't have agreement, I think, as a country, in the way some of those examples that Natasha described have done this work, to think about what do we expect for somebody living in a home? What's the expectation about what a good life looks like? and what's the relationship between the individual, their family and the state, and who's responsible for ensuring that good life. So I think that's fundamentally where we kind of, why this it feels like it's invisible and we've got different views and opinions. And so we need to kind of have that vision for that as we age. So, you know, certainly what's our expectation as we grow old? What's that good life for us? So a colleague referenced that there's a difference between if you're an unpaid carer as an older person, as a woman, to if you're a parent carer. So we kind of got different expectations. We don't, and we're not clear about if I'm born with a life-changing disability, long-term condition that I'll have from the point I'm born to when I die, what's the expectation of that person's life and who should fund a good life for that person, support through their employment. And equally, when we have a health crisis, mental health crisis, substance misuse, maybe comorbidities and a sleeping rough, maybe detained in prison, because social care works in prisons, for example, what's then the expectation of that and what does that good life looks like? So fundamentally, we have some of that work to do to understand that. And I would raise Natasha up to 25 with how many reviews, committee reports, papers that we've had. So I'll raise you, Natasha, to 25. I'm sure some colleagues in the audience might even want to raise beyond that. But
It's like collecting football stickers.
these are quite difficult things to do, and social care is about social justice. Social justice isn't popular, is it? So it's a predominantly female workforce, as colleagues have described as inequity. So it's about poverty, people experiencing deprivation. There are intersectionality about this, about racialised communities, about people with disability. So it's not a popular thing to grasp and to have some of those public debates about. And then I think the other thing I just wanted to draw out is local government alongside healthcare and the NHS and other forms of public service. We've become incredibly short term. And there was some of that debate, I think, in the MP that sort of opened some of this about the accounting issue. It's not just in the way we think about the money, it's what we measure. We often measure, don't we, in hours sometimes, some of these things. We're thinking hours, minutes, days. We're not really thinking about, well, okay, how do we solve tomorrow's problem, not least the problem in 2-3 years to come. So incredibly short term in the way we think about somebody's life course and somebody's health and social care outcomes, in the way that we think about what somebody may need through that life course and what a good life happens. And I think, lastly, just to talk about, I think mentioned about the value. I think we need to kind of tackle some of those issues about how do we value someone's long-term quality of life and start to think about that as being a measure before we can think about some of this about the activity. Because in some ways, it's where you talked about the data and what do we understand about things. In some ways, that's kind of irrelevant if you're thinking about where do we invest in society into people's lives.
Do you think part of it is also that societally we have a fear of decline, of death, of considering ourselves as candidates for both, and of wanting to really, talk about those. We talk a lot about childcare, and that's another sector that has huge issues, but they pale into comparison the social care sector. We're much better at talking about the start of life than we are about the end. And is it a kind of societal, I don't know, rejection, ignorance of older age? And I know social care is not just about old age. I think it's also potentially a rejection of wanting to talk about people with disabilities and long-term care needs because people just they don't find it appealing.
Yeah, about half of the people we support is linked to old age, about half is linked to disability and short-term issues I mentioned, and half is linked to older age. And it does come back to that view about what do we expect as we grow older. And I think a lot of the social care and health options that we have now, whether we're paying for that ourselves or expecting state-funded care, aren't things that we'd probably want to choose for ourselves. And we don't often think about it until the point when it's needed. It's quite difficult, isn't it, when we think about supporting ourselves or our family members to think about what are the things you need to put in place, to age well. It's not something that is part of a daily conversation, so I'd agree with that. And equally, one of the issues about social care was health is very visible. GP practice is very visible. We've got one in every community. People don't often notice or walk past Nadra's, home care office or care without actually sort of clocking it because it's not registered as being needed. So we don't think about it until we're facing it ourselves. So we may have a child with disability who's just moving from special school into adulthood. We may think about it at that point. We may think about it when our partner has a mental health concern and needs some support to, you know, to recover from that. And we may think about it when it's our parents, but unless it's touching our lives in that way, we don't tend to think about the concerns.
Yeah, and it's fascinating, the debate around adaptations as well, because that acknowledges that we ignore it until the point at which it is needed, as opposed to the fact that, you know, obviously some adaptations are entirely unforeseen, but homes could, and, you know, outdoor spaces can be designed in a way that means they don't have to be adapted, that they're actually already ready for somebody who, you know, is 50 in 10 years' time, may find stairs difficult or something like that, and having that sort of, that long-term picture as opposed to just thinking about somebody's needs now. Thea,
Yes.
we've had some strong words about politicians on this panel, I think. How hopeful are you that this is the commission, this is the one that's going to solve it, and that, you know, it obviously won't be implemented until the next Parliament if it does get the go-ahead, but do you feel, as Natasha hinted, that we are at a point where there is potential, there is opportunity, even if the timetable is very much suboptimal?
If you're going to stay in health and social care, you have to have a level of optimism, otherwise you would just go home, wouldn't you? We've already said how many commissions there are. I think when we see the terms of reference of this commission, if we see that it's going to take into account everything we already know and everything we have already done,
Yep.
that will give me some more optimism.
Yeah.
If they're going to redo
Yeah.
what we already know and we've already done, I will have less optimism.
Right, yeah.
And I think if there is a real focus on political consensus, cross-party political consensus with real will, and what Natasha talked about, building a public understanding of this is national infrastructure. This is what we should be as a civilised society. Some different narrative rather than a narrative which is social care is about selling your home and everything else is hidden.
Yep.
If, maybe.
The cross-party consensus question is fascinating, though, because the reason we have political parties is they're groups of people with different views who come together, you know, who group around people who they agree with. And so you're always going to have a fundamentally different view of the state and the role of individual wealth and the role of individual carers, as we talked about in the first session. Fundamentally different view between Labour and the Conservatives. And so my kind of hesitation with cross-party consensus is that I'm not sure it's possible. I'm not necessarily sure whether it's desirable, because I often think that consensus in politics means people end up not asking the difficult
Yeah, they can go to the
questions.
lowest common denominator when you
Yeah.
get to consensus. But I think the work that Natasha talked about suggests that there has to be a level
Yeah.
of cross-party. There has to
Yeah.
be a level, which is what we see in other countries,
Yeah.
that is enough of an understanding, and at very least a cross-party understanding behind closed doors about the need to change the narrative. Because, I mean, I can't remember the politician, but it's a European politician who said actually every political party knows what we need to do, but we don't know what we need to do and also get re-elected.
Yeah.
And I think behind closed doors there is an understanding something significant has to be done, and everybody wants to be re-elected having done it. There's got to be some way in which
Yeah.
they find enough of an agreement to push this through.
Which is why the reporting date of 2028 is not
It's a bit
particularly
bizarre.
helpful, given
It's-
it'll be
a
right
year
at the
before,
point at which
yeah.
they're turning on each other. But
Definitely.
there we go. So, time for questions from the audience now. Front row, as a microphone speeding towards you.
Hello, me again. Thank you, panel. Some really helpful perspectives. And Mel, I think if we can perhaps influence, Mel and Zoo, if we can influence the terms of reference that actually talk about how do we want social care to work to help people have a good life, that could be a triumph, couldn't it? Just to back up Nadra on the impact of the employer national insurance contribution changes, it was a surprise. People can plan for things that they think are coming, but they can't plan for a 10-12% increase in their workforce costs, when their workforce costs are between 70 and 80% of all of their costs. So it is going to be, I think, very, very damaging for providers across the sector. Our members in the not-for-profit sector are certainly telling us how difficult it's going to be. So I wanted to bring us back to a spot of optimism about the Commission, which is that Louise Casey, in my experience, and I worked with her a long time ago, back in the day, when she was doing homelessness and antisocial behaviour and all that stuff, and we were working on the Supporting People programme. She is a woman who likes to get things done, isn't she? So it strikes me that a 3-year time frame for this might be quite challenging for her. And so I guess, how is it that we as a sector, collectively, can help build on her ambition, because she wouldn't have taken this on if she didn't think it was really important. How do you think we can build on what we know of her from her ambitions previously to really get things moving? And back to Thea's point about the terms of reference, we really can't have a repeat of everything that we already know, because we already know Andrew Dillnall was great last week, wasn't he, at the select committee? Last week, this week, whenever it was, just kind of saying we know everything. And even about money, we do.
Yeah.
So we've got an opportunity, collectively, everybody here, to think about how we make that commission do the things we'd really like it to do. Any thoughts?
Thank you for that question. So how can the social care sector build on Louise Casey's ambition to get things moving, and how can you make the case for terms of reference that don't reiterate things that we have already spent 20 years learning? Natasha, small question there.
Yeah, I think I agree, Liz. I mean, there's not a sort of magic source of revenue that we haven't thought about. We know we know the problems, we've got a good diagnosis of the problems, we've got a good sense of what the options are in terms of revenue raising. There's very active stakeholder groups who are ready and willing to engage in designing the system and what it should deliver. So I think that's the point we need to get across the Commission. I mean, I think my understanding is that there's 2 phases to it, and the first phase should report in the middle of next year. And so I think the crucial thing will be, well, what's in that first phase? And then what comes later? Because as I was saying before, what I think we really need to see is the plan. We need to know how the different bits are going to all fit together, and then we can have an implementation over a number of years, perhaps. But I think in the immediate term, well, we need immediate stabilisation, because we are facing a crisis in the provider and local government. But then I think we need to have some urgency around putting in place that plan, and then a timed plan for implementation. So I think that's the message that we want to put forward.
Nadra, without thumping the table, maybe you and Louise could thump the table together, but what's your thoughts?
Well, I mean, I think, just reiterating that we do know what we know, and if you're a consultant in a hospital and you're presented with some ailments and you're told this is what this person has been, having for X amount of time, how long do you leave it before it's too late to act? I think that's the bit. I don't know Louise Casey. I've heard about her in a previous existence. Last year I was the High Sheriff of Kent, so I had the law and order bit under me. She was very well thought of by some of the things that she'd done. So she's somebody who the action, she'll want to get on. Remit really, really needs to be clear so that we know what it is. We as a sector can help her. So can all those 25 or whatever number we want to go with of reports. And if she's going to take time to read all of that, then I kind of really don't have the confidence to know. But if you're going to work on the basis that you know what you know, and then you update it, and the sector will update it with you and let you know where we are, because we've moved. We've moved to healthcare tasks. It's now in there. So providers are providing healthcare tasks. I keep hearing about new initiatives to, if somebody falls, don't call an ambulance. We're moving away from all of that. So she's going to have to look at all of that and the finance behind it. But we need to have some really kind of strategic ways in which she will come forward to show how we complement each other. We're not there just to support the NHS. We're there to complement each other. And the person at the heart of everything we do is what she needs to have on the table. How will this impact that person? And if she can do that and take in everybody's thoughts and views, then that's going to be what we're going to need.
Fantastic. Salome.
Yeah, so we have some manifesto commitments, and I think it's incumbent on us as a sector and partners in the room to remind the government of that. So we had a manifesto commitment for a National Care Service. We had a manifesto commitment for a fair pay agreement, which links into the amount people are paid, so that links into the national insurance contributions. And we also have a whole wealth of initiatives already around reform, and particularly around integration with the NHS. So I think it's about holding the political leadership to account. So we were promised a social care plan for 10 years sitting alongside the NHS 10-year plan. So I think we need to be asking for that plan to be published in the spring alongside the NHS plan, and for the Commission to be a part of that. There's a whole wealth of activity and things that are in train that we need to tackle that we can do so outside of the Commission. So we need to really, I think, hold the politicians to account for saying, well, we can't just be waiting for this plan to be happening at the end of the Commission, then sort of, 13, 14 years' time transforming somebody's outcomes. So that's my take on how we can start to do that, Liz, and to raise that, hold the political feet to the fire, if you like, for that, for their commitments to us.
Waving a manifesto. Thea?
I've got
Anything
nothing to add to that. That's
Fine.
what I've said before.
Lovely.
Thank you.
Okay, another question. Yeah, go on then.
Hi, so I'm Florence. I work for the mental health charity Think Ahead. So we train mental health social workers. I think we see the benefit from first-hand experience of having social workers embedded in health settings, within local authorities and in NHS trusts. And the role they play, and I think we've referenced this earlier, in treating kind of the whole person in a really holistic manner, and helping them both kind of get fit but also stay fit. Unfortunately, we're kind of seeing less and less of them in NHS settings, and quite a lot of the Section 75 agreements kind of being rescinded by local authorities just due to pressures and kind of financial uncertainty. And unfortunately, quite often they're seen as a bit of an overlooked resource, both in kind of workforce planning and in the Darzi report as well. And I suppose it'd be great to hear from the panel, where is that kind of oversight and maybe, short-sightedness and not seeing them as a kind of really valuable resource, where maybe is that coming from, and also what do you see as the role of social workers in kind of social care reform more broadly?
Thea, I'm going to come back to you.
I'm going to ask my colleagues who are more expert. Go for it.
Okay, so I agree. Social work's a really important part of the integrated neighbourhood team. So it's essential that we work alongside social works alongside care workers. So social work has quite a distinct role from care workers. So alongside care workers, district nursing, community matrons, psychiatry, a whole wealth of people that work really hard to keep people well in their homes and as close to home as possible. So I think you're right. I wouldn't suggest that local authorities divorcing sometimes of NHS partners is just down to financial constraints. There's a whole wealth of reasons that many of us have talked about before. So it can be about the models of care, lack of commitment to integration, cultural challenges, disputes about who pays. We've heard a lot of that through the morning about how do we work out who's responsible and who pays for things. So I think there's a whole range of reasons why people disintegrate from what we've had before. But I think the neighbourhood health sort of language and policy is an opportunity if we grasp it, and it's about home, not hospital, about how do you create really important ways to, that we work together to keep people well, and living at home, I think, will be an important way to do that.
Marjorie?
Well, I think obviously social workers are integral to the part of that kind of assessment process, etc. And I think it is important that we do value them. We know there are shortages, but alongside them, I would also list physiotherapists and everybody else in the community who delivers. What we found very, very challenging at one point through the discharge task force piece that we were doing was that we kept saying, where is the wraparound service? It's not just one person that makes a difference. And I think there's a great graph somewhere, it's kind of escapes my mind where I've seen it, which shows the individual and how everybody plays a part into that. So discharging somebody without having that wraparound service outside, without the GPs working with the social worker, without the families working with the, it makes very little difference. So I think it's the resource outside as well, and I think it's something that we talk about quite a lot in the Cavendish Coalition, where there is, there's a huge number of parties sitting around that table who have an interest in the individual. Nothing is silo. Nothing can be just that we need the social workers. It's got to be everybody. And then the plea from the social care part of the sector is involve us. There's no point having multidisciplinary meetings without the registered manager of the service sitting there. Value them as well, because they have a real part to play in all of that. So I think it is a multidisciplinary piece, and the social workers should be the glue, but I think sometimes their work caseloads are so great now, and that's what we found through the Christmas break, where they just could not put the packages together, so people were in hospitals for more than 2 weeks more than they should have been.
Yeah, I think, workforce strategy absolutely has to form part of reform. It's critical. And, it's good to see that the government has moved forward with a fair pay agreement for social care. But my anxiety around that is that it's seemingly being done in isolation of the wider reform.
Yeah,
so
absolutely.
we're seeking to increase pay without thinking about the revenue, without thinking about the impact on providers. So it goes back to the point I was trying to make before about the comprehensive plan and how all of it fit together. Skills for Care have produced a plan. They got frustrated with the absence of a plan coming from government. Skills for Care have done that, so there was one sitting there for the taking. But it's about how we ensure the government picks that up and embeds it in reform. And to your point about professions, yeah, the focus of a lot of reform is on care workers, but actually the professions play a really key part. They're a smaller group and they're often forgotten, but social care nurses are another group that are often overlooked. So we need to be cognizant of all of the different parts of the team.
Thank you, that's really helpful. Leonora has a question.
Leonora Murray from the Nuffield Trust. Thanks. I'm also quite interested in your thoughts on this, Isabel. So I was really interested in the point about cross-party consensus, particularly given we have a government majority. And I wonder on social care if part of the reason everyone talks about cross-party consensus is really that the problem is about money and how to get vast amounts of money spent on something that half the public think is free anyway. And so, just probing that a little bit more on whether we can ever get the money side of this debated in the same way in Westminster. And then also, I'm always thinking about Natasha's point that there was something that happened in other countries that made social care reform a no-brainer. So you talked about financial crash in Japan, for example. I was really struck when I listened to the assisted dying debate how many MPs talked about the huge cost of care at the end of life, or that people might make decisions about opting for assisted dying on the basis of vast social care costs. And I just wondered, do the panel think that the assisted dying debate is going to raise this in a new and a different way? Because it is the first time that we've got this particular focus in Parliament.
Yeah, I think that's so interesting. And I think not just social care, but also palliative care has gone up the agenda, because those working in that field, or those fields, have been able to say, look, by all means have this debate about assisted dying, but why on earth are we not also talking about how to have a good death when that is possible? And they acknowledge that there are some conditions for which that people may think that assisted dying is the only option, but are we resourcing social care, end-of-life care in a way that makes death and decline something that people can bear the thought of more generally outside of those particular conditions? And I mean, my disappointment with the current situation in terms of social care reform is that governments very rarely get more powerful as time goes on, and Keir Starmer has not had the easiest of starts, it has to be said, but things, I mean, his prediction that things will get worse before they get better might be true in some respects, and, you know, let's all hope that that is true. But in terms of political capital, that is very rarely true. And if he thinks that in a second-term Labour government, where some colleagues have likely lost their seats, meaning that those who have returned have, you know, had the bejesus scared out of them even more about the vengeance of their electorate the next time round, and are even more focused on local concerns, and are even less likely to toe the line than they are at the moment, then he's fundamentally misunderstood politics. And so that was I interviewed him a couple of years ago, where he did say to me that social care would be a second-term issue. And I sort of spent the time after that hoping that he'd change his mind, because I don't understand if there's an ideal point at which to do this, which there isn't, but if there's a best point at which to do it, it's now. And if there's an issue that you should be burning your political capital on, it's this. And the choices, the things he has chucked into the flames in terms of political capital so far have been odd, compared to an issue that we do accept, at least within political discourse, if not public discourse, is one of the great public policy failures of our time. We're not going to have the circumstances as we did post-war, where so much of the newspaper coverage during the war was about the need for things to be different in terms of healthcare, and people had come together for the first time and seen either the deprivation of their neighbours in a way that they'd never been aware of, and the lack of access to healthcare. With 47% of people still thinking it's free, we're not going to get to that big public moment. And so, waiting for something better to come along is never going to happen. I think you just have to accept that the further away you are from an election, the safer you are. Just get on with it and, spend your political capital on something that's worthwhile. But what do I know?
A lot.
Tasha?
Yeah, I agree, and I think the time now is for bold political leadership and decision making. And I think Thea's right. You need some measure of cross-party agreement that this is an important issue. But I think we have that actually. In the last election, it was in everyone's manifestos as an important issue. This is the time to act. And I think it's getting that narrative right and really pitching it as this is a social good. This benefits all of us. And unfortunately, I think the narrative has been very much focused on individuals and costs, and unfortunately going down inheritance and property. And it just narrows the relevance of the debate immediately. So we need to get the narrative right, and that's where the politicians really need to step up. And I was interested, you mentioned childcare before, and obviously not a system that is held up as a functioning system, but I think it's really interesting in where the public and policy discourse has shifted away from it being a private, family matter, to actually this is something worthy of the state supporting it.
And of the Treasury thinking about it, not just it being an education issue. Yeah.
Social care needs to be in that exact space. It's a support, it's a pillar of national infrastructure we need to support the economy, to support society, as well as individual lives.
Any other?
Well, I would agree completely that it needs to be seen in that way. And taking Leonora's point that if we accept there is no more money, then there needs to be some bravery that says some of the money that we will inevitably funnel towards exciting new inventions in the health service needs to stop and needs to go into proper infrastructure social care. And I think, there are some hints of optimism where you have had over the last few years big, powerful acute trusts saying, and they are the most powerful in the system, saying we're going to put some of our money into social care because we can see that our part of the system is not working if we do not give this money to our local authority, we do not give this money to social care. Now, that's not universal, but that's really, it's something that you could build political capital on. You could work on the fact that quite a lot of people in the health service increasingly want to support social care. Admittedly, the proximal bit, that bit in the overlap, which they can see, but even if you can move that a bit, you've got a bit more political capital building that wasn't there before a few years ago.
I think just to add in, that's a really interesting question there about what's the role of assisted dying, and it comes back to my point about what do we expect as we grow older, when we have a long-term condition, and what does quality of life mean. So I'd hope, that'd be my ambition, Leonora, that we would have that debate. I think just touching on the points about changing the narrative, so some of the things that I'm really hopeful that this government starts to grasp is looking at the economic impact and contribution of adult social care. So there are different models, but it's somewhere between 40 and 50 billion we think it makes impacts on the economy, and has 1.5 million workforce and supports 2 million people. We don't talk at it as that big mammoth task and social fabric. So I think if we look at it in that way, rather than being about, like as Natasha said, robbing people of their home, or being poor people needing support, if we look at it in that view and see it as part of the government's growth agenda, I'd hope that would also help to shift in the narrative. And some of the things that previous panels have touched on, actually a low cost or cross-government carer strategy doesn't necessarily have a big price tag. So things like resolving fair pay, who pays for care, are big issues that will take longer to resolve and bold political decisions, but there's a whole range of elements where they could just describe and set out political will actually to improve people's lives.
I wonder what is more difficult, achieving cross-party consensus or getting a cross-government strategy to actually work and departments to talk to each other. I'm not entirely sure. Nadja, do you want to...
I was going to make the point that Mel's just made, really, about the contribution social care makes into the economy, which is often kind of dampened down. It is in the kind of 50 plus, depending on where you look at it, and I think that's important. But it's also thinking through the difference we make to every individual that we support, and that makes the difference actually for us as providers, the difference we make in the lives. And one person that we look after has an impact, if you look at their families, on a lot of people, the ability to go out to work, all of those sorts of things, and that adds to the economy as well. I think the narrative has to change, and we keep talking about it. I can't stand this phrase about save social care. I think this is about save social care. It's about valuing social care. We're not standing there with a begging bowl waiting for money. You have to understand, as a government, Keir Starmer needs to stand up and talk about social care in a more positive narrative than he does, and make sure that people, from the people make decisions all the way, are talking about how we value the work that goes on in a social care setting, how we value local authorities supporting providers, how the NHS, values what we do. Because until we start changing that narrative, it's almost as though we're always asking for money, and it's wrong. We're 8.2 billion in the red on this, and that will keep on rising now, and we will see providers go out who don't want to go out.
Well, that's a really cheerful note to end this panel on.
Sorry.
Thank you so much, though, to all of our panellists and to the audience for your contributions, for your questions, for your thoughts. Look, this is not a cheerful subject because we're dealing with a lot of political and policy failure here, but I think what has been absolutely terrific about this conference, and thank you to Nuffield for putting it on, has been that we've had real clarity on what the issues are, what the questions are that need to be asked, and where else to look for ideas, inspiration about so many different issues that are facing the health and care sector. So thank you to this panel, thank you to those who've spoken before, and I think I'm handing over to Thea to close and to tell you what where food is as well.
Yeah, I won't be long between you and food because I like food as well, but I thought I'd move to just be separate from the panel. It's been a real pleasure this morning. A real pleasure, particularly for me, listening to and being alongside my colleagues in the Nuffield and giving them the chance to talk about some of the really exciting work that people do and talking sensibly about international comparators. It's really easy to talk in a poor way around international comparators. It is much more challenging to use that research to really draw things of value. So I hope those of you who become particularly curious will go to the Nuffield Trust website and see even more that colleagues have written. And there are a few things that I want to reflect on overall. One is the issue of visibility, and that's come through from all three panels. And there is something around this overarching question of hospital to home, and I'll come back to why I still hate the phrase hospital to home, which is about the visibility of what goes on in community. Another phrase which is parity of esteem, parity of understanding what's going on, whether it's social care, whether it's primary care, whether it's community services, that those waiting lists, those people, what's going on there matters the same. It needs to be visible, it needs to be seen to matter. And that the work that we do there, I still say we because, full confession, I was the chief exec of Community Trust, so I still feel very passionately about it, is something which is about generalism. And it isn't about specialism. And that's something which is a theme that's come through that maybe I wasn't expecting so much, but is that fact of how we make the generalist the specialist. It is the most special thing to do, to be the generalist, and that is often the social care. It is the district nurse. It is the primary care worker. We haven't spoken enough about the VCSE sector, and we haven't spoken enough about the patient, but I'm glad that we've had the opportunity to always be thinking about the fact that all of us are putting the patient or the citizen at the heart of how we think about all of this. I think there is hope. The reason I hate the phrase hospitals at home is because that's not how we live our lives. We're not sitting here today going, good thing we're not in hospital. I mean, maybe we are. But mostly we're sitting here going, this is where we live. We live in community. Well, we don't live here. But we live in community. We live our lives. Most of us are so lucky. We are not in a hospital. It is a very tiny part ever of our healthcare, our lives journey. And so the thing that we should be talking about is how do we strengthen and how do we make visible the things that really matter, which is community. And it isn't about hospital to home. That actual phrase, I think, is changing the debate in a way that I don't think is helpful. And I'll finally pick on something that Nigel said, which is that a lot of the things about the elements that we need for the future, whether it's neighbourhood, and we could have a whole conference about what neighbourhood means, is a lot of these things are here already. The future is here. As people would say, it's not evenly distributed, but it also isn't funded, recognised and seen. I hope you've enjoyed the morning. I have. We've got some food next door, and please carry on talking. Thank you.